Greetings, I'm Dr. Kinju Adhikari. I'm presenting on our innovation MRI-DTI based 3D prostate models with nerve mapping. The title of my presentation is Seeing Nerves in 3D MRI-DTI Prostate Model. Here we have integrated validation and clinical application of the model. We have no conflict of interest to declare. To begin with the understanding of the unmet need, unlike the kidney and liver, prostate lacks precise 3D anatomical model. In robotic prostatectomy, our vision has improved tremendously, yet one limitation still remains. We cannot see periprostatic nerve fibers. The prostate lacks precise 3D anatomical model. Apex anatomy and bladder anatomy are especially variable, often leading to functional compromise. There is also no true 3D anatomical understanding during biopsy or surgical teaching. This is a gap we set out to address. Here is our innovation. Based on this, our innovation is 3D imaging of the prostate with mapping of nerve fiber tracks. We're the first ones to use diffusion tensor imaging tactography integrated on a 3D model of a prostate. It is based on the sensitivity to diffusion of the water protons in the biological tissue, and the DTI is able to quantify this phenomenon. By integrating this with the prostate surface modeling, we generate a patient-specific 3D models that combine tumor and nerve anatomy in one platform. This gives the surgeon an anatomical roadmap before surgery. The process begins with multiparametric MRI diffusion tensor sequences. Deep learning segmentation or even manual segmentation defines the prostate and surrounding structures. Surface reconstruction converts this into a 3D model, and tactography algorithm then sets to delineate the nerve fibers and helps in preoperative planning. This is a pictorial diagram of the same, where deep learning segmentation bridges the gap between 2D MRI and 3D visualization. After segmenting the prostate and related structure in terms of tumor, neurovascular bundles, apex from the MRI, the next step is the formation of 3D surface reconstruction. DTI captures the directional movement of the water molecules along the axons, and tactography reconstructs this orientation voxel by voxel, forming continuous fiber tracks. When these fiber tracks are superimposed on a prostate model, we obtain a functional anatomical map showing a tumor and nerve relationships unique to each patient. This makes it possible to rotate the prostate, zoom in and out, and explore it from multiple angles, just like handling the organ in real life, but virtually. This steps remains a transformation in the 3D reconstruction from a static image into a dynamic, interactive tool for surgical planning. In the next step, we overlay the DTI-derived nerve fiber tracks onto the reconstructed 3D prostate model. This integration allows us to visualize the neurovascular bundles in relation to the prostate and any tumor location. The result is the patient-specific functional map, anatomy plus nerves, which can guide nerve-sparing decision and enhance preoperative planning. This model allows precise visualization of neurovascular bundles in relation to the prostate and tumor. This is an intraoperative video for unilateral left side nerve sparing robotic radical prostatectomy. On the 3D model below the video, we can appreciate the tumor location on the right side. The tumor is marked as a red on the 3D model, and the orientation of nerve fiber tracks can be visualized on both the left and right side. We are able to completely preserve the neurovascular bundles on the left side, and the margin negativity was confirmed by intraoperative frozen section. We do this by NeuroSafe technique. By mapping neurovascular bundles preoperatively, it provides objective support in deciding whether nerves can be preserved or whether a wider excision is required. It also aids in determining whether unilateral or bilateral nerve sparing is feasible, thereby balancing oncological safety with functional preservation. Here we have completed the left-sided neurovascular bundle preservation, and we can see the marking here. Apical dissection is another one of the most technically demanding steps in radical prostatectomy, and apical and urethral dissection is one of the most important application in terms of using this 3D model. The model highlights the urethral plane and apical fibers, giving the surgeon advanced knowledge of difficult areas. Not just apical and urethral dissection, it also gives a better understanding of base, median lobe, and seminal vesicle anatomy, all helping in improving an outcome of the patient. These models have utility beyond surgery. They can guide targeted biopsy, provide residents, fellows, students with a 3D understanding of a prostate anatomy, and serve as a powerful tool for patient counseling in terms of personalized visual counseling tool and in terms of explaining anatomy and risk linked to any procedures. It also allows outcome correlation, linking anatomy and nerve preservation with recovery of the continence and potency. We validated this approach in 30 patients. Pre-op 3D model reconstruction and planning was done for all patients, and the validation was done in terms of intraoperative frozen section using neurosafe technique and final histopathology. Anatomical concordance with the surgery was 86.6%, and tumor location correlated with the 3D model plus MRI in all cases. Nerve sparing radical prostatectomy was done in 14 patients, out of which 12 had negative frozen sectional margin and 2 required intraoperative revision to achieve negativity. Final histopathology concordance was 100%. Among bilateral nerve sparing patients, potency recovery was 83% at 6 weeks and 92% at 12 weeks. Erectile function was preservation was achieved in the most, with only 17% requiring PDE5 inhibitors. In unilateral nerve sparing, erectile function was lower and all required PDE5 inhibitors. 16 non-nerve sparing cases, 8% had positive margin. Most of them were locally advanced cases. Importantly, surgeons consistently reported the greater confidence in nerve sparing and apical dissection when guided by 3D model. Looking ahead, we plan to integrate these models into augmented and virtual reality platforms, potentially overlaying them onto a robotic console for intraoperative navigation. This could establish a new standard of preoperative planning and extend to focal therapy and other urological procedures. In conclusion, MRI-3DI prostate model is first of its kind. It creates a personalized 3D anatomical models and helps in assisting preoperative planning by improving nerve-sparing decisions, apical dissection, biopsy, training, and counseling of the patient, and potentially have a future scalability in terms of AR, VR, and focal therapy. Thank you.